Once again, namaste, a very warm welcome to today's Aarogya session. Today we are here to discuss common cardiovascular problems. And to begin with, let me tell you that cardiovascular illness is not a single condition, but a group of conditions affecting the heart and the blood vessels. So must have seen, you must have come across high blood pressure, heart failure, heart attack, stroke, cardiac arrhythmias. All this are included in the plethora of cardiovascular problems. And many a times these cardiovascular diseases remain silent, and when only some life-threatening event occurs, you come to know that okay, you have some cardiovascular disease. So this is the part wherein we know that prevention and awareness is the main tool to combat cardiovascular disease. And today we are indeed fortunate to have with us a true beacon of cardiovascular knowledge, Dr. Narang, Professor Narang, Head of the Department of Cardiology, AIIMS, who will guide us through understanding of common cardiovascular problems, their prevention and management. At this juncture, I respectfully invite Dr. Mahesh Sagar, Head of Hospital Services, to formally introduce our esteemed speaker. Sir, please.
Good afternoon, everyone. It's great pleasure to see you all here today for the ninth session of Aarogya Health Talk series. Heart diseases are common today, but the good news is that many can be prevented or managed if we understand them early. In this talk, we will discuss common heart problems, their warning signs, and how small lifestyle changes can keep our heart healthy. It's my profound honor and privilege to introduce to you Dr. Rajeev Narang. Dr. Narang obtained his MD Medicine and DM Cardiology from AIIMS. He pursued further prestigious training at Hammersmith Hospital in London, earning his MRCP from the UK. He returned to his alma mater in 1996 and joined his faculty at AIIMS. He rose to professor at 2008 as higher administrative grade professors in 2016 and head of department since 2024. Dr. Narang is a key architect of national health strategy. He serves as chairman of Niti Aayog, committee focused on indigenously developing advanced heart assist disease devices and artificial hearts, a true fusion of engineering and medicine. He also chairs an expert committee for the Ministry of Health formulating vital guidelines for CT scans. In essence, he's shaping the future of cardiac care for the entire nation. His clinical work includes the management of coronary heart disease, valvular heart conditions, and heart failures. He's an expert in cutting edge investigative and interventional procedures, including TAVI and TAVR, a revolutionary method for replacing heart valves. As a researcher with over 100 international publications, he delves into the very building blocks of heart disease, exploring genetics, biomarkers like microRNA, and next generation materials for stents. Today, with his talk on common cardiovascular disorders, he will illuminate the conditions that are silently becoming more common among young and elderly. He will provide us with actionable wisdom to sustain our heart's health within the framework of a demanding and ambitious living. It's now my great pleasure to call on stage Dr. Rajeev Narang. Dr. Narang, please.
Morning, good evening, all of you. It's really nice to be here in this August institution. IIT Delhi is well known for its excellence, well known for its contribution to the country, the academic level, the professional level. So we all look up to IIT Delhi for various things, and it's my privilege to be able to come here and to speak to you today. So, as Dr. Mahesh Sagar very nicely mentioned about, and Dr. Yasmin also mentioned about the heart disease, which is important condition, and it it is serious, but at the same time it is preventable. So let me just so I'll be talking about the common cardiovascular ailments. It's a heart, basically heart and blood vessels. So um, this is kind of a continuum, which uh, initially there is a kind of risk, and progressively it kind of may lead to functional failure of the heart. So we have to be careful to the best way is to prevent the risk itself, rather than because later on once disease occurs, once damage occurs, then sometime it is a little difficult to reverse everything. So we have to be careful that we have to be right from beginning we have to risk factors and how to kind of prevent it. So if you see this burden of disease, the burden of diseases, various diseases we consider in terms, of course, of deaths, that how many deaths are occurring because of this disease, and also in terms of what is called we call daily, that is a disability adjusted life years. So how much disability it is causing. So it's not only if the disease may not cause death, but if it causes a lot of disability, that is also an important feature that the patient has suffering, so that has to be prevented. So that is, so in terms of both disease, deaths and disabilities, heart disease are one of the most important conditions. Globally, about one third of all deaths are because of heart disease, and about in India about a quarter of deaths are because of the heart disease. So if you are able to prevent it, if you are able to control it, then it's going to significantly enhance the longevity. In terms of Delhi is also like this is a there was a major global burden of disease study conducted by um, uh, Bill Gates Foundation, and all over the world they checked about the various diseases, and this particular illustration shows us that how much is the distribution all over the world. And we see here that red means that there is a higher burden. So if we see the developed countries like Europe and USA, actually is more in blue, more lesser, while the burden disease actually is more in India. So this is because both because of the numbers of population there, and of course, we the South Asians have a little bit of a predisposition also to heart disease. So we also have predisposition to kind of abdominal obesity. So, and that is an important risk factor, as we'll see, is an important risk factor for heart disease. So, heart disease is not really only kind of a condition of the West, it is our condition, it's our problem now, and we have to very much uh, take care of it, look into it, learn about it, and prevent it. So, if you just see the very basic idea about the cardiovascular system, we should know that heart is basically a pump. The heart is a pump which has to supply blood to all parts of the body, and the blood goes through. So, blood collects nutrients from the gut, it collects oxygen from the lungs, and then it has to provide the nutrients and blood to the oxygen to all parts of the body, especially to the brain and the liver, to kidneys and muscle and all those all tissues. So if the heart stops, then it's a big problem for all tissues, and especially for the brain, because brain person will become unconscious within a few seconds if heart stops, and within 5 minutes person may have permanent brain damage that will indicate death basically. So it's remarkable actually that the heart keeps pumping all throughout our lives, day and night, and providing blood to the all the parts of the body. So the human system is actually so complex that machines, we can't think a machine working like this. So this is that is why the importance occurs that if there is a problem, if heart stops because of some reason, then there will be immediate problem. And if the heart becomes weak, then what happens is, because as you know, the pump it's a pump, so pump has to push the blood forward, and if it is not able to push blood forward, behind it the blood will get accumulated. So there'll be accumulation of blood in the lungs, in the body. So patient will have difficulty in breathing. Patient will have difficulty in walking, etc., because of fatigue and swelling of the feet, etc. These things will occur. So that is a condition called heart failure. We'll discuss a little more. So these are the various common, cardiovascular diseases which occur: high blood pressure or hypertension, high blood cholesterol, which leads to heart disease in due course, coronary heart disease, which includes angina and heart attacks, heart failure, the rhythm problems, and we have the valvular heart disease, the peripheral vascular disease, and stroke. So they are also part of the heart diseases. Stroke is called the which is like the heart attack for the brain, basically, because the blood, there is a blockage of blood supplying to the brain, and then the part of the brain dies. So that leads to, and the brain has two halves, right and left half. So if one side gets damaged, the other side of the body becomes paralyzed. So that I'm not going into detail because it is actually discussed more by the neurologist, and but it is part of the same disease pattern of the blood vessels. So of course, the hypertension, high blood pressure is a very important condition. It's a very common condition also. Almost 25% of adult population they have high blood pressure, and but the main point is it's very easy to detect. It is also very easy to treat. The only problem is that it's a kind of a silent disease. It doesn't cause problem in the immediate term. So if the blood pressure is a little high, about 160 or so, then it can continue for a long period without any person having any symptoms. And but it predisposes to more serious heart disease, and it can suddenly cause problem. It means the patient may have suddenly have a heart attack, the patient may suddenly have a brain stroke. So that kind of problem. So that is why some people call it silent killer. So but the main good point is that it is easily detectable, it is easily treatable. So basically this uh, uh, normally when we see the blood pressure defined as two numbers, upper number and lower number, like 120 by 80. So because heart is a pump, it's a pulsatile pump. It when it contracts, the blood pressure rises, and when it relaxes, the blood pressure falls. So the blood pressure rises to 120 millimeter mercury and falls to 980 millimeter mercury. So this is how the pressure is moving in the varying in the bloodstream, and that is what is detected, and that is what is controlled. So one should know that more than, if the upper one, which called systolic blood pressure, if it is more than 140, or if lower is more than 90, then definitely it is hypertension. So and this should be kept less than 140 by 90, and if it is not repeatedly coming as more than 140/90, then one needs some medication to control it. And the blood pressure instrument, any person who has been detected, is best for them to buy and keep a blood pressure instrument at home, and then one can check it. And actually the home BP monitoring is now considered to be the gold standard of diagnosis of high blood pressure, because when one comes to the hospital, sometimes person has anxiety, especially on seeing the hospital environment. Also, if person is coming to hospital, he's maybe walking a little bit distance, so he's exerting, with exertion the blood pressure rises. So therefore the blood pressure which is detected in the hospital, or the clinic blood pressure, that often is high. And there's a thing called white coat hypertension. You see a person in white coat, then you feel that you get a little anxious, and your blood pressure may be higher. So home BP monitoring is very important, and it's also very easy. The instruments are not very expensive these days. So what is the cause? Usually the blood pressure is kind of a, it's called essential hypertension. That way the cause is not known. It is just because of, with a little growing age, the arteries become little stiffer, and therefore the pressure kind of rises. And but in some cases, about 10% cases is called secondary, because the patient has some other disease, especially if the patient has kidney disease, or narrowing of the main artery, which is called aorta, or the patient is on steroid drugs, or some tumors are there, then they also cause high blood pressure. So patients with kidney disease very often have got high blood pressure. They have to be given medicines to control the blood pressure. So what if patient has high blood pressure, what test do we do? So we have to do blood tests initially, because we have to rule out if there is secondary cause is there, like if the kidney dysfunction is there, or if the blood patient has high blood sugar, diabetes, or high cholesterol, because these are also risk factor for heart disease. High blood pressure itself can cause further heart disease. So therefore we should control all possible heart risk factors to prevent further heart disease. And we see that in the ECG, because heart is also like a muscle. Heart is a muscular pump. So if the pressure is high, if heart has to tackle high blood pressure, it will become thicker. Like the if you keep doing a lot of gym exercises, weights, etc., your muscles become thick. Similarly, the heart muscle also become thick if the pressure is high. Like this, it has become thick, and this gets reflected in the ECG as tall voltages. So we had to do ECG in these patients regularly to find out if there is an effect on the heart that is occurring. The X-ray chest will show heart and lungs if any effect is there, and of course echo will visualize these muscle of the heart to see if there is any thickening, etc. We can see the valves also in echo if they are getting affected. So how do we treat it? We treat basically these are the common medicines which are given to patients with high blood pressure. Like amlodipine, cilindipine is one which is mentioned. There are calcium blockers, and telmisartan, losartan, ramipril. These are called a angiotensin receptor blocker or ACE inhibitors. Then there is some agents which are actually they cause increase in the urine output. They are called diuretics. Mild diuretic agents are there. So they also lead to increased urine output. Then the blood pressure comes a little lower, comes down. Then beta blockers are there like metoprolol, bisoprolol. Sometimes these are they are not first line agent. Earlier they used to be first line agent, but now they are not first line agent. Other ones are tried first, and other agents are also there. So so hypertension, as I mentioned, that this is kind of maybe a silent killer. So it's important to have it checked regularly. So all patients who have been detected high blood pressure, all patients who have heart disease, and generally even healthy persons who have grown up, once in a year or once in 6 months, you should get it checked. So I mentioned about the disease, the causes, and symptoms and complications. So symptoms, especially if the blood pressure remains high, as I mentioned, more than 40, 150, 160, it remains with some, then the patient starts having breathing difficulty. On walking, the patient start feeling a little breathless, or the patient may develop swelling of the feet, edema. Edema may occur. That is, the feet may become swollen. So if somebody has a swelling of the feet, or if somebody has breathing difficulty on walking, one should get the BP checked. It may be high, and controlling the BP reverses these changes. So these symptoms get relieved easily by control of the blood pressure by medication. And I mentioned that if they are untreated, if the blood pressure is untreated, then it can lead to various complications like stroke, heart attack, kidney damage, vision problem occasionally. So then this is the cholesterol. The cholesterol, high cholesterol is another risk factor for the heart disease. And so because the heart disease, this is called atherosclerotic process, that in the blood vessel, in the inner wall of the blood vessel, the fat gets deposited, and this causes gradual narrowing of the arteries, and therefore the flow of blood reduces. So or this can even get completely blocked off. So the lipid, therefore, it is important that lipids should be under control. Lipids should be reduced, and there are studies which have shown that adequate lipid control reduces the heart disease in long run. So that is why one has to be clear about the diet, and also one should be control his weight. Weight is important because weight, especially abdominal obesity, which occurs, that is often associated with the lipid abnormalities, and that leads to later on heart disease. So this is the coronary heart disease is the we're now coming to that into the heart. These coronary arteries are actually the blood vessel which supply blood to the heart muscle itself. Because although heart is pumping blood, it is not deriving nutrients from the blood in the cavity. It has its own arteries which supply blood to the heart muscle, and therefore normally they are clean, they are inside or patent and in lumen. But if there is a deposition of plaque, if plaque gets deposited inside, the heart vessels get narrowed, and blood supply will reduce to the muscle, and therefore the person can have problems. And uh, sometimes there is a partial problem, they cause angina. Partial obstruction cause angina, which is kind of chest pain on exertion. And sometimes a sudden complete obstruction occurs, this leads to heart attack. So angina and heart attack, they are often the features of cornea disease. So very often patients' diagnosis mentioned as CAD. So this is important. This is cornea disease, which may lead to angina or will lead to myocardial infarction or heart attacks. So as I mentioned that there is a this is a deposition of the fat in the arteries, and this process is called atherosclerosis, and this occurs when it occurs in the heart, artery supplying blood to the heart, then it causes angina and heart attack. If this disease occurs in the artery supplying blood to the brain, it may cause stroke. If a disease occur in the arteries of the leg, then it may lead to gangrene. It may lead to pain on the walking in the lower limbs, and the same if narrowing occurs. If narrowing occurs in arteries going to the kidneys, then it will cause high blood pressure. So these are various manifestation of basically same underlying atherosclerotic disease, which is the fat deposition in the arteries. So this is extremely important. So as I mentioned, this is basically when you have narrowing, then blood supply to the heart muscle reduces, and so the symptom will depend on the blood supply versus the oxygen demand. So angina, what happens in angina? Angina basically person is all right at rest, but when person starts walking or climbing stairs or does some exertion, lifting heavy weight, etc., then because he has to do more work, the heart has to supply more blood to the muscles while walking, climbing stairs, running, etc. So then the blood supply become less, because then the balance disturbs, because the blood supply is now restricted because of that narrowing in the blood vessels. Blood supply cannot increase further while oxygen demand is increasing, and therefore the person start getting chest pain or angina. So when the person stops, when person starts rest or take some medicine, the medicine or tablets available which he can keep under the tongue, and that leads to dilatation of the vessels, and that leads to relief of angina. So now this is a very important slide. Basically these are all the risk factors which may lead to atherosclerosis or narrowing of the arteries, and we have to focus on these risk factors. There was a big study which is called Inter-Heart study, and in that study these 8 risk factors were identified, and most importantly that these 8 risk factors, if they are controlled, then vast majority of the burden of heart attacks will come down. So smoking is the first, mentioned as the first. It is the most important, and it can be easily prevented also. You can stop smoking, and actually most people have actually these days stopped smoking. There are very few smokers these days as compared to earlier era, although it still continues to be a problem in some areas, but vast majority of people, they have left smoking. Diabetes is another one. Diabetes predisposes to heart disease, atherosclerosis, and therefore heart disease. High blood pressure, I mentioned high blood pressure is important, therefore important to keep control. High blood cholesterol. So these are the 4 kind of major risk factors, and there are 4 other along with this. One is abdominal obesity, as I mentioned. If the weight is more, especially if the waist is more, then is a risk factor. Then psychosocial stress. Stress is also chronic stress. Stress is also leads to more risk of heart disease. Lack of physical exercise. So this was proven in the study that those people who exercise regularly, they get less heart diseases. And lack of fruits and vegetables in their diet. This was also from the study only, that those people who eat more fruits and vegetables regularly, they have lesser heart disease. So these are all important risk factors one should keep in mind. So as I mentioned, that angina vector, which is basically pain in the chest, especially classically it occurs when person exerting, like climbing stairs or walking long distance, carrying weight, etc. And it's more in the cold weather. So during winter, during these days, one has to be careful. More after heavy meals, and it's over center of the chest, generally subside quickly on rest, or if medicines which are kept under tongue for relief, then the chest pain becomes better. So what tests do we do? What investigations do we do in patients who we suspect to have angina? Of course, we do the blood investigation to find out about the lipids, about sugar, and about other condition may be there. ECG, we check if there are any damage to the heart, because it's important to note that in patient with angina, the ECG may be normal. So therefore, some patients come that they have angina, but they are happy that their ECG is normal, which is happy. It's good that it ECG normal, but it does not rule out angina, because ECG changes occur only when there is a irreversible damage to the heart which occurs. Suppose there is a damage to part of the heart, then ECG changes are more there. With the angina only, there is what is called ischemia. When person exert, there is a lack of blood supply to the heart muscle, there is ischemia, and therefore the person gets chest discomfort. But when he rests, it becomes all right. So muscle is still all right. Muscle is not permanently damaged. ECG changes occur when there is a permanent damage to the heart muscle. So we do the X-ray chest that shows us the heart, the size of the heart in the chambers. Echocardiography is very important. It shows all the chambers of the heart. Then stress test is extremely important. So here we subject the person to stress, like a treadmill exercise most commonly, and then in a treadmill test we do a simple review the ECG of the patient during that period, and that when person stresses, then the ECG changes of ischemia occurs. But better test is actually stress MPI, because treadmill test is often false positive. So very often people come with us that they have some chest pain, they underwent stress test and it was positive, and then now they are very worried, even though the pain was not really like angina. So one thing, anginal pain is a central chest pain, and it's a kind of pressure-like sensation, a compression, and it occurs on exertion. So some people come that they have a pricking sensation. At this point, there is a pricking feeling. So that is not angina. That is unlikely to be angina. Similarly, the pain on the side of the chest, etc., that is not angina. So one should not get worried. So one should consult the doctor to see whether it is angina, whether some test needs to be done or not. So, treadmill test, especially in the women, sometimes it is false positive. So better test is actually what is called a stress MPI test, or stress thallium scan. It used to be called earlier, because thallium was used. Now thallium is not used. It's called MPI, myocardial perfusion imaging. So here, after making the patient exercise on the treadmill, one does a scanning of the heart, and that one will know exactly which part of the heart muscle is getting ischemic, which part of the heart muscle is damaged. That is a much more accurate test. And therefore, very often we find that patients who have got treadmill positive, but we feel that no, it is not angina. We get the stress MPI done, that is often negative, and then the patient is reassured that everything is all right. So some other tests, calcium scoring, very often people come, they are recommended calcium scoring. So because this atherosclerosis often is associated with a little calcium in the arteries, and when CT scan is done, it picks up calcium more accurately. So, but the only thing is that this calcium scoring is less correlative than the stress test, etc. And by calcium scoring itself is not an indication of further doing angiography and all. So angiography, like CT angiography or invasive angiography, that is done to actually see the arteries of the heart by injecting contrast in the blood and scanning the heart. So invasive angiography is the gold standard, but CT angiography is like a CT scan. So it's only a venous line is put, only the vein in the arm is cannulated, and the contrast injected through that. So one has to be careful that generally, if patient has got mild symptom, like patient says I can climb 2-3 stories, so then it's a mild. So then there is no need to undergo angiography. If the patient has problem like walking small short distances or chest pain at rest, then of course it is indicated. Then of course one should go straight for angiography. But if some person says I can walk long distance to I can climb 2-3 stories, then it is, if there is suspicion of angina, one should undergo a stress test, and that will show us whether it's a true angina or it's some other chest pain. So how do we treat angina? Basically, the first of course is the medication. And there are two medicine. One is this aspirin, and second are statins. So aspirin is to it prevents blood clotting, and statins, they lower the cholesterol. And these two agents, they are known to improve the outcomes of patients with angina and heart attacks. So therefore, it's very important to take these. These are more important if the patient is diagnosed as angina, if the patient is diagnosed to have coronary artery disease, then these are given, and they're generally given for lifelong. And statin lipid lowering also for patients who have got heart disease and advise statin, there the lipids actually will lower quite a bit, and we lower it to less than 55. The average usual cholesterol, this we are talking about what is called LDL cholesterol. LDL is what is most important, low density lipoprotein cholesterol, and usually in average person generally it's about 130, 140, maybe 150 or so. So if the patient does not have any risk factors, then less than 150 also is all right. If the patient has some other risk factors like high blood pressure, diabetes, etc., we try to then bring it down, bring it less, less than 100. Any patient who actually have a heart disease, we keep it very low. We try to give it less than 55. So therefore, cholesterol is extremely important, and the target level depends on what is the rest of the profile of the patient is. How many risk factors he has got, how much, whether he has already got heart disease or not. Those are the factors to be considered. So then there's a nitrate, and then there is a metoprolol, etc. Beta blocker. They are for the angina relief. So they lead to improvement in the supply demand ratio. So therefore the patient does not get angina. So they are for the symptom relief. But in the long term, more benefit is with this aspirin and statin. Aspirin is also important to prevent blood clotting, because sometimes, as I told you, that plaque may rupture and the blood may clot over that, causing sudden occlusion. If the sudden occlusion, it will lead to heart attacks. So therefore, aspirin prevents heart attacks in patients who have got angina. So these are the important things to note. If the drugs are not kind of effective, patient has more disease, angina is continuing, then we need to take more stronger treatment measures, just as angioplasty or bypass surgery. So what is done in angioplasty? As I told you, that there is a block in the artery. So basically, idea is to open the block so that the narrowing disappears. And initially, these angioplasty, the tiny catheters, they are passed, from artery, either from the groin or from the wrist, and then they are advanced to reach the coronary arteries of the heart. And there, the obstruction is initially closed with a thin wire, and over the wire then we pass a balloon, collapsed balloon, and we inflate that balloon there so as to open the obstruction. But generally a metal alloy stent is also deployed at that site to keep the vessel patent. Otherwise the vessel either tend to recoil back immediately or after some time, or may develop a restenosis in the due course in next ensuing few months, and therefore stent placement prevents most of that. And these days the stents are a drug eluting stent, they also have drug coating there, and they prevent restenosis to occur. So that is the standard procedure which is done. And in those patients who have got multiple blocks are there, long blocks are there, and especially in patients with diabetes, then the chances of stents getting reoccluded and further events occurring are more, because stent placement, they carry a little bit of risk also, and therefore chances of risk is also more if multiple occlusions are there. And therefore in those patients bypass surgery is recommended. And in bypass surgery, the surgeons, they have to open the chest and they place bypass grafts. They bypass the obstructions using arteries in the chest or veins from the leg. So there is a normal artery is called internal memory artery, which is coming to the thoracic wall, and that artery is separate from thoracic wall and it's put on the artery of the heart. So if there is a obstruction here, that obstruction is bypassed, and now the distal artery is getting blood from internal memory artery. Or one can take from the legs one can take the vein, and then vein one uses as a kind of a graft to bypass the obstruction in the artery. So there was obstruction here, but a vein has been put from this aorta, bigger artery, to the distal part, so that now blood flows to the distal heart muscle properly. So that may have to be done if multiple blocks are there. So coming to the myocardial infarction in heart attack, this is obviously the most dreaded complication. And what happens here is, most commonly, there's a plaque rupture. That plaque is there that has got a lipid, and that kind of surface becomes eroded and rupture. And on that irregular surface, blood clots. And this leads to sudden occlusion of the artery. And therefore, the blood going to the heart muscle suddenly stops. And if it, the sudden occlusion there, so one part of the heart will start dying basically, and the patient will have severe chest pain and a lot of apprehension and nausea, vomiting may be there. The patient may also get breathing difficulty, fainting can occur. This is because the heart failure can occur immediately, and rhythm problem can occur, so heart may stop actually. So sudden death can occur. So it is a very dreaded complaint. We have to be very careful. We have to do all measures to prevent it. So how is it treated? So most importantly, the early treatment is extremely important, because as the time passes, if you're outside hospital, then immediately rhythm problems, etc., can occur, heart failure can occur. Then so we have to be in the hospital as quickly as possible. So if severe chest pain is occurring, one should go to the nearest hospital emergency. That is extremely important. There one can get support. So, because as time passes, then permanent muscle damage occurs in case of delay. And initially, the patients may be given, immediately aspirin that helps the clot kind of lyses. And there are special clot busting agent which is called thrombolytic agents, like streptokinase or TPA or tenecteplase. These agents are there. They lyse the clot and therefore open the artery. And the another one is urgent angioplasty. Urgent is called primary angioplasty. The patient taken to cath lab, and that, as I mentioned, that the wire, arteries are cannulated and the wire is placed, and the block which is there, thrombus which is there, is opened by the balloon. Then we place a stent so that the flow is restored in the artery and the heart muscle is kind of salvaged. But important point to note is that often, if somebody is not near the major hospital where cath labs are there, then also if in a peripheral hospital, these thrombolytic agents are available, and therefore they should be given, and then the patient may be transported to the near hospital. If one can reach the nearby hospital early, then that is preferred. So it's not only the early cath lab, primary angioplasty is the modality. Thrombolytic agents are also an important modality which are available, and that should be resorted to if the patient is in a peripheral hospital. So treatment, if it occurs within 1 hour, of course, that leads to almost complete recovery of the muscle. But as the time passes, then the chances of recovery of the muscle become much lesser. And after 6 hours, generally, the chances of recovery of the muscle become lesser. So little permanent muscle damage kind of tends to occur. So if the muscle is permanently damaged by a heart attack, then later on, the patient may get into heart failure. So what is heart failure? Basically, it is because of weak heart. A weak heart is unable to pump enough blood to the body. Therefore, like this is kind of normal heart, which is a normal muscle thickness is there. It will contract normally, and the weak heart become thin walled and become dilated, and so then it's not able to pump out blood adequately to the body, and therefore the fluid pools in the lungs will become congested, and therefore person has breathing difficulty. And as I mentioned, fluid pools in the body under the skin leads to like swelling of the feet, and sometimes fluid get collected in the chest cavity or abdomen also, because the heart is not able to pump the blood adequately. So these are all shortness of breath and swelling of the feet. These are all features of kind of heart failure. So sometimes the heart failure is not always caused by the previous heart attack. Sometimes there is some disease of the heart, which we call myocarditis or cardiomyopathy. That also leads to weakness of the heart, and that leads to heart failure symptom. And although drugs can be given to kind of control the situation, but in some cases the drugs are not useful, and they are not able to control the heart failure fully, because muscle is really very weak and it's not kind of improving on medication also. Then sometimes you have to resort to cardiac transplantation, heart transplantation. That situation comes. So what investigation done in patient with heart failure? Of course, blood is also important, because sometimes even low hemoglobin, many factors, they can aggravate the heart failure. And if you correct these factors, the heart failure become much better. The patient become much better. If there is low hemoglobin, anemia is there. If iron deficiency is there, if kidney or liver may be getting affected, we can see that on the blood testing. If the thyroid conditions are there, thyroid hyperactivity is there, that leads to heart failure. So therefore, that can be corrected. And of course, the lipids, cholesterol should also be controlled, so that there is no further heart attack. If one heart attack has occurred and the heart muscle has become weaker, and subsequent heart attack will cause even, it will become even more riskier. So we have to be careful to prevent any further episodes. So apart from blood, ECG, X-ray, echo, angio, these are all investigations. Like an X-ray, we find that the cardiomegaly, very often it is mentioned that heart enlarged हो गया, बताते हैं डॉक्टर कि heart has become larger. So that basically means because heart is weaker and therefore it has got dilated a little bit. This same thing we can see on echocardiography also, that the ventricle is quite dilated. Normally it's not this dilated. Then sometimes the valves start leaking, like this is the ventricle, this is atrium, this is a valve, this is a mitral valve, and the valve is leaking. The blood is going from the ventricle back to the atrium, so this valve leakage occurs, so that kind of complication can come. So how how is this treated? How is the heart failure treated? So there are some agents which are there. There are, of course, the most common drugs which increase the urine output, because fluid is getting retained in the body. The heart is not pumping adequately, fluid is getting retained. And but if we give drugs which increase urine output, that fluid gets out, and therefore the swelling of the feet become lesser. The congestion in the lungs become better, so patient is able to feel, breathe better. The breathing difficulty becomes lesser. Then other drugs are also there. Beta blocker, metoprolol, etc. are often given. This ACE inhibitors, ramipril, and Arni, and like Vimada and Losartan, Telmisartan, they are also given. They also lead to long-term improvement in heart failure features. Then there is a SGLT2, like empagliflozin and dapagliflozin. These agents are there. They are actually drug for diabetes, but it has been found that they are also useful for heart failure. So these are the four agents which are they are called the four pillars of heart failure therapy, and they very often, most patients, vast number of patients, they lead to control of the heart failure symptoms. So so as I said, this is kind of a heart failure is a kind of mechanical exhaustion, and this is normal heart size. The heart become dilated and heart failure. And as I mentioned, the various things, the causes can be coronary disease with heart attacks, high blood pressure. If the long history of high blood pressure and heart pressure rises too much, then also heart failure will occur. Valve problem may lead to heart failure. So various conditions can cause heart failure. So as I mentioned that so apart from medicines which are given to control the heart failure, sometimes special pacemaker type of they are put. So these are the pacemakers are put, and they have two leads to two chambers of the heart, because in heart failure often there is a discoordination between the two chambers. They're not coordinating, they're not synchronized. So this is called the cardiac resynchronization therapy, CRT. Very often heart failure patient, they are advised these agents, that these pacemaker to be put. They are a little costly. They cost between 3 to 5 lakhs depending on the chamber they pace. So that sometimes is advised. And if of course that is also not beneficial, then sometimes the patient, we have to give more advanced surgeries, as I mentioned earlier, that these patients may need heart transplantation. That may be there. So then finally I'll talk a little bit about the heart rhythm disorders, because the heart may be everything normal, structurally it is normal, contracting quite all right, valves are also normal, but the heart normally contracts in a kind of a rhythmic manner, and about rate of about 60 to 90 per minute. So this is the so this one, sorry, I can't get the pointer. Now you can see the pointer. So this, the upper strip is basically the normal, what's called normal sinus rhythm. So there is a this is called the P wave. Then this is called the QRS complex, and this is the T wave. So normally it comes in order. P waves indicate contraction of the upper chambers of the heart called atria. QRS complex, which cause contraction of the main ventricles of the heart, and the T wave is kind of a recovery of the ventricles. So this is the wave pattern. This is normal sinus rhythm, which is perfectly all right. Now this, in this condition, if we see that the baseline is not straight, kind of here it is kind of reasonably straight with definite wave patterns are there. Here the baseline is irregular, and therefore actually the atria are not contracting properly, not contracting, beating rhythmically, but they are kind of fibrillating. There is a irregular contraction of the atria, which is basically they are not contracting. But since the ventricles are the main chambers of the heart, main pumping chamber, the patient is reasonably all right. Patient is not, doesn't have heart failure, but also you see that there is an irregular rhythm. So some of these atrial complexes, they reach the ventricle, contract the heart, sometime early, sometime little late. So this is irregular. So this is a condition which is called atrial fibrillation, and this is kind of becoming more common as the society is having advancing age. The longevity is increasing. There are more elderly people in society. This is more of a condition of the elderly. And so this is atrial fibrillation coming up. And the lowest this shows that this is the atrial contraction, but there is no ventricle, there is no QRS complex. This atria has actually not conducted. So this is a complete heart block. This is a slow rate. The heart rate obviously is slow, and this is called complete heart block, because ventricles are now, they have to contract on their own, and their own rate, their intrinsic rate is actually slow. And therefore the patient has a heart which is contracting very slowly, let's say 30 beats per minute rather than normal 70. At least 60 to 100 is considered to be normal. So if it is less than 60, the patient start getting symptoms. If suppose it's 35, 30, so the patient start getting symptom of giddiness, dizziness, because less blood is going to brain, and the brain needs blood all the time. And so the patient start getting giddiness. And suppose sometimes there is a pause, the heart stops for 5-7 seconds, and then the person may become unconscious. Patient may fall unconscious. The patient generally falls. This is called syncope. We call it syncope. Then as soon as the patient falls and the patient lies down, then the blood supply to brain increases. So therefore, any person who has got a kind of giddiness occurring, having giddiness, etc., especially because of heart condition, he should lie down. If you can lie down, the blood doesn't have to go under against gravity to reach brain. The blood goes to brain more easily, and therefore the person doesn't get unconsciousness. So, and for this condition, basically drugs are generally not very useful. Pacemakers have to be implanted. And the pacemaker that I showed you in the previous one, there's a device, and this is kept in the left upper chest mostly, and the lead, these are the lead, these leads are advanced into the ventricles, and this pulse keeps generating small electrical pulses at about 70 per minute or 80 per minute, and the heart keeps contracting at the proper rate rather than becoming slow. So that needs to be done in patients with heart rhythm disorders. So this is basically to summarize that the basic, some initial conditions are there which are silent, like high blood pressure, hypercholesterolemia, high cholesterol levels, etc. They lead to structural disease, and they lead to more catastrophic problem like heart attacks, heart failure, rhythm problems, etc. So this is again the atrial fibrillation, which is becoming more common these days. And this is about the stroke, which I did mention. If there is a blood supply stops going to the brain, that part of the brain becomes dead, and and that supplies the opposite half of the body, and the opposite heart become paralyzed. So that is the similar condition, because in the arteries the problem is similar, atherosclerosis, which is causing. One important point to note about this is often mentioned with atrial fibrillation, because in atrial fibrillation, the atria, these are the upper chamber of the heart, which are atria. The lower chamber, the ventricle, they are the main pumping chamber, but blood is coming through the atria. And atria also, as I mentioned, normally keeps contracting normally, properly. The P wave is there in the ECG. But if they are not contracting regularly, then they are kind of fibrillating, means they are actually not pushing the blood. So there is stasis of the blood. So the stasis of the blood gets clotted. The blood clot occurs, like this, stagnant blood gets clotted, and this blood clot forms here, and this clot may get released from the wall, and now it is in the blood flow. It goes to the ventricle, it goes to aorta, it goes to brain, and once it reaches the brain, it may cause obstruction there. And therefore this part of the brain becomes dead, and patient may get a stroke. So therefore, patient with atrial fibrillation, they are often given medicines to reduce clotting. Again, they are given medicines called anticoagulant agents, which are given, especially apixaban is one, or rivaroxaban, warfarin, dabigatran. These are the common medicines which are given to prevent blood clotting and therefore reduce the risk of stroke in patients with atrial fibrillation. So that is, I have not gone into details about the valvular disease, which is another major topic. The heart has got 4 valves. The 2 are between the atria and the ventricles. And if they are narrowed, then there is a problem because blood is not flowing. Behind the obstruction, the blood will get pooling, will be there. Pressure will be high. Patient may get into breathing difficulty, etc. And especially we are saying then there are two valves which are there, which are for the great arteries, like this is the aorta, this is the pulmonary artery. And this aortic valve, the aortic valve stenosis is again a problem of the elderly, and this is kind of increasing. And traditionally it needs surgery to be done, but now we are doing, it can be done without surgery also. We pass a collapsed valve from the artery of the groin, and we reach the heart around in this area, and there we inflate the valve to deploy it, so it becomes as normal valve is there without surgery. So that there's a TAVI or the tower procedure that we are doing. So so this is the main thing about the prevention of heart disease. See, the three components are very important. The exercise, regular exercise is extremely important. Then the nutrition control, diet is extremely important. So diet generally we tell the best is to remember three things to remember: low salt, low sugar, and low fat. Salt, sugar, and fat one should keep less. Low salt leads to control the blood pressure. High salt leads to retention of fluid in the body, and therefore BP rises. Low sugar also lead to decrease in the obesity. It also reduce blood sugar, and therefore diabetes chances become lesser. So that is important. And low fat, of course, to lead to reduce in the cholesterol, reduce the body weight, and therefore that benefits. So this is what we should. And basically, one should target a ideal body weight. If the body weight is high, one should reduce all diet basically, so as to reduce the body weight to back to ideal level. And then of course you should avoid smoking and limit the alcohol. Smoking is extremely important because smoking is definitely a major risk factor for the heart disease. Thank you. So I hope it was useful. If there any question, we'll be happy to take.
Thanks, sir, for that informative session. And now we invite you to ask your questions. Someone will get you the mic. Please ask your questions.
Hello. I wanted to ask, like, is it advisable to use treadmill during winters, especially in December and January? Like running at 9 kilometers per hour or 12 kilometers per hour.
Yes. So, treadmill is a good exercise. There is nothing wrong in it.
Hmm.
Treadmill is a good exercise, and many people do regularly. It's a
Hmm.
standard part of the many gyms, etc. Also,
Hmm.
the only point one should keep in mind is that two, three things. One is that one should do a little warm up also
Okay.
initially. One should do a little warm up,
Hmm.
and then one should increase the speed or
Hmm.
increase the slope and go ahead.
Hmm.
Second important point to think note is that if you are getting symptom, if you're getting too much breathless,
Hmm.
if you're getting some chest pain, if you're getting fatigue,
Hmm.
if you're getting any giddiness, then you should stop. So don't push yourself too much also. So with regularity to doing regularly,
Hmm.
one will build up the stamina, one will build up the exercise capacity, but one should not try to do too much, try to get too much out of it. So competitive sports is a little they can be dangerous for ordinary persons. So
Hmm.
if you are in competitive sports, then you should undergo proper training, proper coaching, and proper monitoring, etc. With that you should undergo. But for usual persons who undergo exercise, one should be little gentle. So
Hmm.
moderate exercise is what is generally recommended.
Hmm.
So you should regularly do treadmill. That is a very good exercise, and especially during winters. You asked, actually it is better because you are inside. Ambient temperature is better. You can control the room temperature and then do exercise rather than going out. Then it is a little difficult because during, as I mentioned, during cold weather, patients who have got heart disease, they should be careful because cold weather is known to cause aggravate angina, as I showed. It leads to vasoconstriction, the narrowing of the blood vessels, and therefore the reduced blood supply to various areas. It also leads to little higher blood pressure during winters is there. So all the factors are there. So treadmill is actually better, but one should keep these points in mind.
But is there a consistent observation that air pollution in Delhi, for example, like above 400, or maybe the projected value is 400, while the actual numbers are close to 4 digits? Do you think like that has a major role in cardiac disease?
So there are studies have been there. So the pollution is linked. High pollution is linked to some increase in cardiovascular risk also, as respiratory and other conditions. There, I'm talking about mainly cardiovascular. So the cities which have got a more pollution, the risk is little increased. There is definitely increase, although you know it doesn't occur immediately, but in long term, and also some increase is there. So so pollution definitely a risk factor. Pollution is definitely, so it must be controlled. That is there. So one has to keep that in mind, and therefore generally we advise that one should not go into exercising in during the when the is more pollution is there, like in the late in the evening, sometime more pollution is there. So one should be careful, especially the afternoon time is generally the best. The pollution is also lesser, the temperature is also better. So if one has to go for walks, etc., that is the best time. During lunchtime one can have quick lunch and then one can go for a little walk. Or those who are retired, etc., they can easily tailor their time. Most patient heart disease, they are generally in the retirement age, so they can easily go into go for walks, etc., during lunchtime rather than during the winters. Lunchtime is a better time to go for a walk.
But I saw whole of India was above 150, while I mean Delhi was like 400, 500, and so on, like last week.
That's a
So,
pollution issue. Why pollution is more here? That is a different thing, basically.
no. I mean, do you see the heart patients are more in Delhi as opposed to say South India?
See, for exactly for the exact numbers, how much increase is there? I'm talking about study which have been done in US and other places also. So the some studies have shown that there is a the risk is there. But to say in Delhi it has increased, one has to analyze the data. One has to see how many patients are coming. So that way one has to analyze and then exactly get how much is the change.
Okay, thank you.
Thank you for the insightful talk, sir. Sir, I want to ask, if someone has a normal BP or a slightly low BP but constantly high pulse, so what can it lead to? And especially it is because of some medicine which has to be consumed regularly.
No, so what you are saying is the low blood pressure. You are saying generally we
No,
say.
no. The blood pressure is normal, but the pulse is high always.
So if the pulse is high, then there could be some causes could be there, high blood pressure, high pulse rate, especially thyroid overactivity is a very important factor. One should be ruled out. That should be ruled out. That leads to high pulse rate. So and that can be easily done by blood test. You should first of course you have to consult your doctor, and they will analyze if the other factors are there. So they have to be seen. Then ECG should be done to find out what exactly is the fast hearted due to, is it a what you call sinus tachycardia only, or some heart rhythm problem? Because some of the heart rhythm problem, even like atrial fibrillation I mentioned, that lead to a faster pulse rate. So that ECG will pick up, we'll get to know on ECG that what is the underlying rhythm which is there. So why it should be investigated, it should be checked
So if
basically.
thyroid issue is also ruled out and ECG is more or less normal, then what could it do?
No, so one has to see a kind of chronic anxiety may be one reason that when during anxiety pulse rate is a little more. If we are organic causes are ruled out, that could be one of the reasons. So when I individual one, it is difficult to, but difficult to say. One has to evaluate the patient fully. But if all tests are normal, then very often chronic stress or anxiety is one reason which may be there, which may be there, which may be causing that. So often there's a 24-hour ECG monitoring, what you call Holter monitoring test, that can be done because that will show us the rhythm over the 24-hour period, and so that will give better insight into at what time the pulse rate is high, what time pulse rate is low, is it normal all the time, sinus rhythm all the time, or some abnormal rhythm is there, and during sleep how is it, if it during sleep it settles down or not, that all those things can be seen.
All right, sir. Thank you so much.
Well, hi. Yeah. So maybe you can just say again, so people may not have heard.
Sometimes the blood pressure becomes resistant. With so many medications, it doesn't come down at all. So, what could be the reason for that?
So resistant hypertension is a very important condition. Basically on giving multiple medication, the blood pressure is not getting controlled. So there could be several reasons. Sometimes reason is not determined also, but as I mentioned, in some cases, secondary causes are there. So those secondary causes must be excluded in these conditions. So one, of course, is a kidney disorder. So patient with kidney disorder very often have high blood pressure, resistant blood pressure. Second are the endocrine disorder like steroid excess, what we call Cushing syndrome, etc., or catecholamine excess, pheochromocytoma, that kind of thing. They may also lead to resistant hypertension. Then one important thing we should mention is that that we call the patient to have resistant hypertension if it is not controlled despite adding a diuretic, because very often patients are taking other medicine but not a diuretic, and they say blood pressure is not getting controlled. So there we give them diuretic, and very often the blood pressure gets controlled. So that is important. That is so we should not diagnose resistant hypertension without giving a diuretic. That one should know. Otherwise, one has to investigate. Aldosterone, high aldosterone levels also, they are also cause. So one can look into this. Sometimes aortic narrowing is there. That can lead to resistant hypertension. So there are multiple causes are there. One needs to investigate surely.
Okay, thank you very much. Thanks for the nice talk.
Yeah, thanks for the nice talk, sir. Indeed. So, sir, I have a question. Like, for men who are near their almost like in their mid 70s or women in the late 60s. So, stress tests regarding stress tests. So, is stress test feasible for them at all? So, what tests, alternate tests can be done? Are stress tests safe at all? And also, like for women, also for often you see that at once they cross 60 or something, they begin to have problems like uh, arthritis or some problem. So, walking and all might as exercise becomes a little tricky. So what exercise do you also you suggest?
Right. Those are very important question. These are very, because very often patients are there who are not able to exercise, because I showed the classical stress test is done on treadmill because that is the kind of easiest, and most data is there on treadmill. It's also most convenient. So, but patients who have got joint disorders or elderly patients who are frail and who are not able to walk briskly, so there we use what is called pharmacological stress test. So we give some medicines by the IV infusion, intravenous infusion. Like we can give dobutamine, we can give adenosine, we can give dipridamol. These are some agents, which are other agents are also there, which we can give. So they simulate kind of stress on the heart, and then we scan the heart. We see whether any changes are occurring or not. So pharmacological stress test can be done in these patients. Alternatively, one can do CT and CT angio also. One can test as an alternative to stress test. One can to see the whether the arteries have disease or not. That can be done. So this is one. Second point is you mentioned very, because we generally recommend that exercise is very good for the heart. But patients who have got joint disorders, we ask them who have got bilateral arthritis, both sides knee arthritis, they're not able to walk. Then the important thing for them is that very often the orthopedician, they advise them physiotherapy for knees, for other joints, etc. So that physiotherapy they should do regularly, religiously, done twice a day, whatever they recommend, because that kind of exercise also puts little stress on the heart, and that's a good exercise for the heart also. So one thing, that physiotherapy they should do regularly. Second point is that even if the lower limb, they are not able to walk and all, but they can do upper limb exercise, gentle weight exercise, upper limb, or even keeping the hands up and on the sideways. So one can do many exercises sitting on the chair also. So upper limb exercise one can do, that will also help. So the other point, we tell them that if their orthopedician doctor is advising that they should get joint replacement, then they should get it done. Or if they want some injections to be done, then they should get it done, so that joint become better and they're able to walk, and that will lead to better heart health also. So very often patient have got joint problem and they're not walking, but they're not getting their joints treated. So these very often the joint problems are treatable, but so we encourage them to get the joints also treated, so then they can walk, and then that will prevent their heart disease from worsening.
Thank you for the talk, sir. Sir, I have two questions. First is, does blood donation help in upkeeping the heart health? Does blood donation help in upkeeping the heart health? Donation of blood? And the second question is, sir, after a partial ischemic stroke, some patients have, like I have a person at my home, and she has disorientation and other issues. So how long does that go? Because I was initially told that it will go up for like 45 days, but it's more than 90 days, so, and still happens. So how long does it go, like the disorientation and confusion
So
things?
first question is regarding blood donation. So blood donation doesn't have any relation with the heart disease actually. So whether it improves heart health, blood donation is safe this thing, and some evidence is there regular blood donation may improve health. So that will include heart health also, but otherwise there is no clear kind of relation. We don't advise, for better heart health you should donate blood. That is not really, but it's neutral. There is no deleterious effect of the donation on heart. That is one thing. Second point is that patient actually who are older and who actually heart disease, then they don't take that. They are not taken for blood donation. That we have to be careful. The third point is that you mentioned the other thing about the ischemic stroke. That I'm not the best person. Neurologists, generally they look after this condition. They say why it is not improving, why it is, how long will it take. Those questions I think you should address to the neurology area.
It was very nice talk, Dr. Narang. I have two questions. One is you mentioned about TMT being false positive. Is it possible to have, is it possible that this TMT is false negative? That is first question. The second one is you mentioned about two drugs like, aspirin and apixaban. So if someone's taking apixaban, will it have the same positive influence like aspirin, or they are completely mutually exclusive as such?
No. So first question you mentioned about treadmill testing false negative. Of course, false negative can also be there. It is less common, but it is there because the test also has got a sensitivity and specificity. So if it's not 100%, none of them is 100%. So therefore, there are false positives. Sometimes false negatives are there. So we have sometimes such patients. That patient is complaining of recurrent chest pain. We get stress test done, that is negative, but we try to reassure the patient. But patient comes again after a couple of weeks, then say no, I'm still having that. Then we have to subject them to angiography. We have to see whether so it does happen that the test is negative, but if patient is continuing to have symptoms, then we do an angiography to find out if the disease is there or not. And your second question was with the aspirin versus apixaban, etc. So there are two actually different categories. Aspirin is an antiplatelet agent, which is kind of a little minor kind of a clot busting agent, but it's more important on the arterial side clots. While apixaban belongs to the oral anticoagulant category, which is stronger but is more effective on the venous side of the system. So these two are there. So for arterial side, like heart attacks, for strokes, etc., then aspirin is used for but for the venous problem like the DVT, like deep vein thrombosis or atrial fibrillation, which is atrial is actually on the venous side. So there the oral anticoagulation are used, which are basically either they can be traditional like warfarin, etc., or they can be newer. They can like apixaban, rivaroxaban, or dabigatran. So these ones are used. Other person can also listen. Interesting question.
एक्चुअली जिसकी प्लेटलेट कम है, क्योंकि उसका तो ब्लड ऑलरेडी थिन है, तो उसका तो कम होना चाहिए, हार्ट रिस्क सही है.
बिल्कुल, इसमें you are right, absolutely. Sit down is a very good logical thinking. This is actually true also. The patients who have got reduced platelets, then we actually stop aspirin, etc. Patient platelet going down, they have bleeding tendency actually. So they have less of clotting tendency, they have more of bleeding tendency, and therefore we don't give oral anticoagulation, etc. to those patients. So that is important. The only thing is that those in this low platelets is not a good condition because it leads to bleeding. It causes problems, and therefore we don't have many patients. They go to hematology. So this also occurs generally in the younger age group. One, it occurs younger age group. Secondly, older patient who have kind of leukemia, for example, older patient leukemia or some malignancy, there the platelet may go down and they may start getting bleeding, etc. So then we stop our antiplatelet agent like aspirin, apixaban, we stop. So you are absolutely right, but only thing is that these are generally they don't occur together. Usually they don't occur together.
Hello, sir. Thank you so much for the nice talk. Sir, when is the ICD implantation advised to the patient? In what case?
Right. So that's a good question. So ICD is a implantable cardioverter defibrillator, and those patients who are at risk for developing what is called ventricular tachycardia, which can cause sudden cardiac arrest and death. So there, it is advised. So what are these patients who have got risk factors? Risk for ventricular tachycardia. Here the ventricles start contracting very fast, like atrial fibrillation. Atria are contracting. Here the ventricles are contracting, and that has become very risky. The patient may get dizziness, giddiness. The patient may fall down, and patient may die also. So the patients who have got large heart attacks, generally, and if they have had episode of ventricular, so there are two kind of indication. One is the primary prevention, second is the secondary prevention. Secondary prevention is those who actually have some episode of ventricular which was life threatening, from which patient recovered either spontaneously or so by medication, or sometimes we give a DC shock to revert it. So that is second. Is there the benefit is definitely much more to get a ICD. And the underlying condition could be many. Like I mentioned, previous heart attack is one condition which predisposes to ventricular tachycardia. Then underlying cardiomyopathies, if they are there, they also predispose. Then sometimes rhythm disorder like long QT syndrome or Brugada syndrome, or other channelopathy. They're called channelopathy because the cell membrane channels are affected there, or hypertrophic cardiomyopathy where the muscle is abnormally thickened. So these are the patients who are at higher risk for VT, and therefore, especially those who have had one episode, they should definitely get ICD for secondary prevention. But there are some patients who get VT because some precipitation, like suppose somebody gets a low potassium because of some reason, like diuretic, which the agents which cause more urine to go out, their potassium gets also goes out more with the urine, and their blood potassium comes down, and that leads to ventricular tachycardia. If you correct the potassium, the heart becomes all right, stable. So there it may not be. We don't put ICD. We don't give them ICD because it was a reversible, preventable cause, and we will, of course, take care in future that the potassium doesn't go down. So that kind of thing. Then other agent, those patients who have got a large heart attack, for example, or hypertrophic cardiomyopathy, or long QT syndrome, etc. Sometimes ICD may be indicated for primary prevention also, that they have not had any VT in the past, but still to prevent further episode, you may give an ICD. So one has to see the actual patient. We have to individualize, see exact patient. What is the indication, whether to give or not to give.
Okay, so thank you.
Hello, sir. I want to ask a question for my mother. Actually, her heart rate is so very slow that if not from stethoscope, we are not able to hear it, or we can't able to feel it, her heart rate, heartbeats. And even when we try to feel her nerves here, we are not able to feel her blood flow. So, what could be the reason behind it?
I think this maybe why do you want to hear the heartbeat? Why do you want to feel the pulse? Patient is all right. You're not a medical person, so you should not do. What you should do is, if there any symptom, you should bring it to our notice. Second, you should check the blood pressure. Blood pressure at that stage must be checked. So what is the blood pressure? Because in blood pressure instrument also gives the heart rate reading. So what is the reading coming there? That you should rely on. That is if that is all right, then everything is all right. There's no point unnecessarily investigating.
Okay. Thank you, sir.
Yeah, good evening, sir. I just want to say something because it's a very nice talk. First of all, hello. Hello. Yeah.
Yes.
I said, first of all, it's a very nice talk. It's very informative.
Thank
But
you.
I have just question day-to-day life. Actually, you said that it is a keeping a blood pressure monitoring machine at home and to check your blood pressure. So actually, sir, we do that. But one result is very confusing because if I monitor my blood pressure is a different time of the day, it varies. Even if I do in the consecutive days also, it's a vary. Suppose if it is 120 per 80 to 140, some days per 90. So what data generally you will believe actually, whether I'm in good track or I need to consult some doctor? What that is?
So generally, see the body systems are not completely stable all the time. Little bit of variation is always there. It is not like a fan which you fix at one speed, it will go at one speed only, but it keeps varying little bit. And especially if you are walking around, if you are exerting, then the rate rises. pressure also rises. So one thing is that we have to check the blood pressure well after resting. So one should be rested for 5-10 minutes and then only check the blood pressure. So some patients don't do this mistake that they go out for walk and they do a brisk walk, they come out immediately and they check the blood pressure. That will be high. That is normal phenomena. That is not a this is normal physiological response. That is not abnormal. Second point is there is no point so therefore there is no point checking the blood pressure frequently also. We encourage people to check blood pressure, but that is once or twice a week. If it is all right, if there is no problem, they are not on any medicines, etc., then once in month is sufficient. But if they are on treatment, then once a week is also sufficient. But if it is not controlled, then twice a day or maximum thrice a day. There is no need to take more than that. What you can do is what also sometimes is recommended, that when you check the blood pressure, you check it twice and take the second reading only, because sometimes the first reading, because of some anxiety or something, maybe a little, do it twice and take a record the second reading. So you should make a, whenever you check, make a record of a date and time blood pressure. So, and then whenever you go to your doctor, you can just show that chart, because seeing those multiple values, that give a very good idea about what is your average blood pressure, what is so whether we need to control it further or not. So that is one thing. So you should not be worried about the variation in the blood pressure. The range that we recommend generally is between about 110 to 140 is the range, and you should try to focus mainly on that. The lower one generally should be less than 90, varies from 60 to 90, that is all right. But upper one should be between 110 to 140. If it is coming less than 110, one should reduce the medicine. If it is going more than 110, one may discuss your doctor whether you need to increase the medicines. So that is what you should.
Thank you, sir.
Thank you. Thank you, doctor. So, thank you for the wonderful talk. So, actually, sir, I have a query that.
So one thing I find, just young person like you, I just so as I was mentioning that smoking most people have omitted. Smoking, most people have omitted. They have stopped. I'm just talking. So there's new slogan that sitting is the new smoking. People that like people like us, we have to sit for long period in our offices, in our desks, etc. So sitting is the new smoking. So one should and if you see people often, so at least whenever you get an opportunity to stand, it is better.
Thank you for that. I'll make that in mind. So my query is that, is there any relation or is there any effect of high hemoglobin levels on on heart health, or is there any relation between the two?
Right. So the hemoglobin is important. You can sit down. That the hemoglobin is important, and especially low hemoglobin. Low hemoglobin leads to worsening of heart condition. So that is very important. Both angina gets worse, and heart failure symptoms get worse. Shortness of breath, etc., get worse. Severe swelling of the feet becomes more. Therefore, any person with heart disease, if we get the routine blood test done and we check the hemoglobin, if hemoglobin is low, then correction of that anemia leads to improvement of the heart symptom. Because otherwise, you may get advised angiography and surgery, etc., because of worse symptom. But if hemoglobin is not correct, so that should be corrected before going for more stronger interventions. All right. So the other thing is that iron deficiency, which also often associated with low hemoglobin, correction of that has been shown to improve the prognosis in patients with heart failure. Outcomes in heart failure patient is better if the iron deficiency is corrected. So that is also another thing. So that is why we tend to get the iron studies also for all patients with heart disease. So if the iron deficiency is there, we tend to correct it. That is the thing. Secondly, the high hemoglobin, that is sometimes occurs because of diseases. One is a polycythemia vera is one condition. That's an uncommon condition, like a cancer of the red blood cells. So when the red blood cells become more and there's a high hemoglobin level, and that can lead to high blood pressure. That can lead to high blood pressure. That may lead to more viscous blood and decreased blood flow to the brain, etc. Patient may get giddiness, etc. Those things can occur. So it does affect. But these are some of the relation between hemoglobin and the heart.
Thank you so much, sir. One question I had for you is that is there any recommendation that when we should start checking lipid profile, in which age group should we start screening for dyslipidemia?
Right. So that's a very important question. So it should be actually whenever a blood test is done, if the lipids have not been done, let's say, so it depends on age of the person. In younger persons, whenever a blood test is done and lipids are not done in the previous 5 years, one should get lipid done so that one can just check, because often high lipid levels, etc., are familial. They are there from younger age also, and they can cause disease in the past. So they are silent. They don't cause any problem at that stage, but in later stage they will lead to greater risk of heart disease. So that is one. Beyond the age of kind of 40, we become more frequent. Every 2 years you can get it done. Beyond age of 50, annual checkups are important. At the time of annual checkup, one should get definitely lipid profile also done. And it should be not just total cholesterol, it should be lipid profile, because what is most important is the LDL cholesterol, and that is the target for control. So that is what we should see.
Thank you, sir. Thank you for answering all our questions with so much patience. Now I invite Mrs. B. Chandra, retired faculty from Department of Mathematics, to felicitate our esteemed speaker. And I also request Dr. Sagar, our head hospital services, to join, please. I extend my heartfelt thanks to Professor Dr. Narang for sharing his insights. Thank you to our esteemed dignitaries, DDO Sir, Professor A.K. Nima, Dean Academics, Professor C.T. Dhania, and Associate Dean Academics Orni, Professor Shilpi Sharma, for their continued guidance and encouragement. I would also like to thank Dr. Mahesh Sagar, Head of Hospital Services, for his support and for guiding all our Aarogya health session. I also wish to acknowledge the tireless efforts of the Orni team members, Mr. Ajay and Ms. Shivani, the IIT Delhi Hospital staff, Ms. Reena and Mr. Pawan, and Mr. Manoj from ETSC for their invaluable behind-the-scene contribution. And thank you all for your participation today. Your presence made this session meaningful. Let us continue to learn, to stay aware, and to work together for better cardiovascular health. Wish you all good health. Thank you. Thank you, sir.